We believe that amyloid plaque, almost like a bubblegum substance, is made or elaborated in an Alzheimer patient, and it's that bubblegum substance, that sticky protein substance that interferes with brain functioning. So what happens in the brain of an Alzheimer patient, we believe that this amyloid plaque then sits in various areas of the brain cortex, the cerebral cortex, and in so doing disrupts the normal communication between brain cells. If that happens, that can predispose to a dementia disorder. We know that dementia is different than short-term memory loss. For example, we all have short-term memory loss, meaning I forgot where I put my car keys, I forgot maybe even where I parked my car at the mall. Forgot that I had dinner reservations with friends tonight. So it's not unusual to have forgetfulness. But if you have short-term memory loss that is accompanied by some other problem with activities of daily living, balancing your checkbook, being able to read documents, remembering what you just learned from a newscast, that suggests a dementia disorder. And that's something that really does warrant a neurological evaluation because that is not normal. Memory loss with another decline in functional activities could spell a dementia disorder, and that is a neurological condition. Remember, dementia has multiple causes. Alzheimer's disease is, of course, the most common cause, but if you get shot in the head, that can cause dementia. If you have a stroke, that can cause dementia. Oftentimes, certain Parkinson's patients get a dementia disorder. Purpose of today's discussion, however, is to focus on the Alzheimer's cause of dementia. And by far, Alzheimer's is the largest cause of dementia in the US and worldwide. So what do we do with a patient who comes in complaining of some problems with short-term memory and also describing some problems of activities of daily living, what we call ADLs, being able to make your meals, wash your clothes, take your bath, all of those things, activities of daily living. So if you have a problem with short-term memory and you're starting to experience some decline of ADLs, that could spell a dementia disorder, and that means you need to go to the neurologist. So what is it that we neurologists do in order to evaluate a dementia? Well, the first thing we do is we take a history, and it's very important that if you or a loved one is fearful of a dementia condition or concerned about it, that when you go to the doctor, when you go to the neurologist, you bring someone who can serve as your, quote, independent historian. Someone who can say, yep, he's having trouble driving his car. Yep, she's having trouble making her breakfast. Yep, ordinarily the house was always immaculate and now it's a mess. So those are the types of things that an independent historian, that a neighbor, a friend, family member, daughter, relative can all help in the assessment, because I need that information from an independent historian when I'm trying to assess a dementia condition. So patient comes into the office, independent historian then weighs in and says, yep, mom's not doing too well when it comes to cleaning the house or making her meals. If that's the case, we have to suspect a dementia. So what we do is an examination is performed. Always, I like to examine the patient to make sure, A, there's nothing else going on, that this is not diabetes out of control or a blood pressure of 180 over 100, that the patient doesn't have a heart attack in place. The other comorbidities that someone can have as one approaches midlife can often present in a dementia-like fashion. So it's very important that an examination be taken and that we get a good history from the patient, seeing what other medicines they're on. Sometimes if folks are on high-dose painkillers, that can present like a dementia. So it's very important that we take a very good history. Then we conduct the examination. In most cases of dementia, the examination is actually unremarkable, except for what the patient is telling me. You're not going to see a lot of overt clinical signs that say, aha, that's Alzheimer's disease. So what we do is a series of tests then. After examining the patient, we typically do something called a mini mental status exam. And a mini mental status exam is a 30-point quiz that really assesses your cognitive functioning at that point in time. What is today's date? What is the day of the week? What is your home address? Spell the word world backwards. I'm going to give you 3 objects, lock them in your brain because I'm going to ask you in a few minutes to repeat them back. That's called a mini mental status exam. And typically normal on a mini mental status is greater than 26 out of 30. So if you get 26, 27, 28, 29, or 30 out of 30, then that is considered to be a normal mini mental status exam. Now remember, someone can have dementia with a normal mini mental status exam. So for example, a highly educated individual, someone, let's say, who's trained as a speech pathologist or has a master's degree or an attorney or a physician or someone highly educated, can often fake out the mini mental status exam. So it's always important before I take a mini mental status exam to ask you, what's your level of education? A high school graduate will not do as well on a mini mental status as a master's degree. So it's always important to get what's called the pre-morbid level of functionality, pre-morbid educational attainment. Very, very important, because sometimes a college professor can fake out a mini mental status exam. Family will say, gee, Professor Dibbs is not able to make his breakfast, but you interview Professor Dibbs, you examine Professor Dibbs, and you suddenly realize that his mini mental status is fine, but the family's telling you that something is off. So very important to know what the pre-morbid, pre-disease level of education and functionality is. So that's the mini mental status exam. And then we do something called a clinical dementia rating. And what that does is tell me how the patient is doing with their hobbies, with their social activities, with doing things around the house, with getting dressed and making meals. That's called a CDR, Clinical Dementia Rating Scale. And typically, we scale that anywhere from 0 to 3. The higher the number, the worse you are. So, patient comes in, family says, problems with memory and some other activities of daily living. I do an exam. We then commit the patient to a mini mental status exam. This is all done in the office. A clinical dementia rating scale. We do a brief screen for depression. I want to make sure that there's no severe depression, because sometimes a severe depression can cause what's known as a pseudo-dementia. People who are very depressed aren't going to do well on a mini mental status exam. They're not going to answer the questions. So severe depression has to be evaluated. And that's done by way of what's called a PHQ-9, a physician's health questionnaire. And it's a 9-item inventory that asks you about your mood. Everything from, are you contemplating suicide, to how is your sleep? So that's an important component. That's number 3 of the 4 tests that are used. And then the final bedside test that's done in the office is called an Activities of Daily Living Inventory. I want to find out how your meal preparation is going, how your driving is going, how your dressing is going, how your homemaking is going. That's called a depression inventory. Typically, those 4 tests are bundled up into a thing that we call a cognitive assessment. So we examine the patient, make a presumptive diagnosis of dementia, again, ruling out metabolic or heart disease, typical things that are common and easily addressed by neurologists. And then once we make a diagnosis of dementia, I think it's very important to stage the dementia, and that's where our cognitive assessment plays a role. That's where we can figure out if this is a mild, moderate, or severe case. In most instances in my office, I see mild, because by the time you're severe, you're in a nursing home, and mild is what gets you to the doctor. So if the patient is mild and brought in, that's good, because that means we can intervene. So we do the exam, we do the cognitive assessment, which has those 4 things: mini mental status, clinical dementia rating scale, depression inventory, and activities of daily living. We bundle that all up, and then we send the patient for an MRI. I always like to look at a picture of the brain, an MRI, because that's going to rule out a stroke, a tumor, advanced multiple sclerosis, which is usually not the case, because the patient would have come to clinical attention well before their dementia if they had MS. So we can see on the MRI that in most cases of dementia, the MRI is completely unremarkable. And then the fourth phase, the fourth test that must be conducted is to actually see if there's amyloid plaque on the brain. Because as we discussed earlier, the amyloid plaque is what we think is actually a biomarker for the Alzheimer's disease. So we need to see if there's amyloid plaque. Now, certain dementias don't have amyloid plaque, but in Alzheimer's disease, there is amyloid plaque. And there's two ways to figure out if your patient has amyloid plaque. The first way is to do a scan. It's called an amyvid scan. It's like an MRI, only you get a little bit of a tracer injected into your vein. You then go into the scanner, and if it lights up, voila, you have amyloid plaque. The second test that we can do is a spinal tap, whereby we put a small needle in someone's back, take off about a teaspoon of clear cerebrospinal fluid, send that off to the lab, and in approximately 3 days, we'll know whether there's amyloid plaque in the central nervous system. So with those four components, meaning clinical diagnosis, cognitive assessment, brain MRI, spinal fluid or amyvid scan to test for the presence of beta amyloid, with those four simple things, and basically to do all four of these things doesn't take more than about a week. With that, we will have a great understanding as to whether you are suffering from Alzheimer's disease. And as I said, most of the time when the patient comes into my office, it's mild. So severe patients, that's already in the nursing home and already been evaluated. But mild is what we like to capture. Mild is what we like to see. As in most of medicine, the milder the condition, the more treatable it is. And that's the same thing with Alzheimer's disease, because now there's a new FDA-approved treatment for the management of mild Alzheimer's. Well, it's actually for Alzheimer's disease, but the significant data is in the mild case, as you would expect with any type of condition. The more mild the condition, the better it's going to respond to treatment. Alzheimer's is no different. So with Alzheimer's disease, we like to get these patients in the mild setting. And then if the patient is mild, and if the MRI is unremarkable and the beta amyloid is there, and the patient doesn't have any other significant medical problems, like on blood thinners, for example, then we would recommend starting the Aduhelm medication, the brand new medication. And as I just said, the medicine is actually approved for Alzheimer's disease. However, the most significant data resides in the mild setting. So oftentimes I'm asked by family members or someone in the community, gee, mom's in a nursing home. Do you think this Aduhelm would help? The answer is probably not, because we like to reserve it for the mild individuals, those who have good baseline functionality. But the FDA data, the FDA indication for Aduhelm, which is this Biogen-made drug, is very good. And basically, it's the only thing we've got for the treatment of mild Alzheimer's disease. So at this point, what we always like to do is capture the patient as early as possible. And then once we make that diagnosis of mild Alzheimer's, which is easy to make, that patient is then sent for infusions. And Aduhelm right now is a monthly infusion, and gradually the dose is increased of each infusion as the patient goes through the monthly infusion. So first month is a lower dose, and then the dose works its way up over the ensuing months. And we believe that based upon the FDA data, the information that was sent to the FDA and the actual package insert, the product labeling, that patients should do well. And this has been my experience. We've been infusing Aduhelm now in our practice since mid-July. We have several patients that we've already infused. So far, the tolerability seems to be very, very good. And patients seem to be doing well on this medicine. Obviously, we are following these patients over the long haul to see how they progress. But again, what we're doing is very much consistent with what the clinical trials were for this Aduhelm medication. So at this point, I am reaching out to all of you. If you know someone, loved one, family member, neighbor, friend, who you believe is suffering from a mild Alzheimer's condition, now is the time to act. Why? Because we know that people progress in Alzheimer's disease. meaning you've got 2 years of mild, you've got about 2 years of moderate, and then boom, you're in the severe setting. So time is of the essence. So if you are observing someone who is a mild dementia patient that you're concerned about, could this be Alzheimer's? Now is the time to act, because we know that those patients by definition are going to progress. Because as you know, Alzheimer's is a neurodegenerative process, and the patients only stay mild for a finite period of time. Basically, we think that that time is about 2 years. So it's important to intervene as quickly as possible. In our practice, First Choice Neurology, we've been pretty good at getting insurance coverage for the Aduhelm medication. If it's a commercial insurance that the patient has, typically we get a prior authorization. And with those elements that I discussed before, meaning unremarkable MRI, mild, positive beta amyloid, insurances really don't have trouble with authorizing it. Medicare tends to be a little more tricky, but that process is being worked out, and we have no doubt that all of our patients are going to be able to get the medication, and if worse comes to worse, we have access to samples of medication to get the patient started, because the last thing we want to do is delay treatment. As I've said over and over today, mild is when you want to get that patient. It's when you want to get anybody with any disease. Alzheimer's, cancer, bad toenail, mild is always when you want to attack. And that's why I'm reaching out to you today on Facebook Live to just say, if you know anybody who has mild Alzheimer's disease, please refer them to your neurologist, to myself or one of my colleagues, and we are on standby, eager, willing, and really excited about getting those patients evaluated and treated as quickly as possible. So I bring this message to you today to say that time is of the essence. This is a call to action. We have treatment now that is available for mild Alzheimer's disease in hopes of maintaining functionality. So this is all important news, new news. I couldn't have done this several months ago because the drug was not available. So it's important that you get your loved one or whoever you are concerned about an Alzheimer diagnosis to neurological attention as soon as possible, and then we can act. If you would like to just have a discussion about whether you think Aduhelm is a reasonable treatment for either yourself or someone else without going through a formal examination, just use our interface, our NeuroChat interface. It's called Neuro2Go, Neuro, number 2, go.com, and you can schedule a 15-minute chat with myself or one of our board-certified neurologists to see if this new medication, if this new Aduhelm may be useful for you or a loved one. Getting some questions about Privigen that you see on TV that's made from jellyfish. Honestly, I haven't ever met a smart jellyfish, and if they were that smart, why would they wash up on the seashore and then let the sea go away and then they die and boil in the sun? So I'm not a big fan of Privigen. There's really no evidence-based data to support Privigen for Alzheimer's disease. In fact, when you see it advertised, they say for brain health, but that doesn't mean that it's going to treat a disease. In my practice, in my business, we see disease, and we see Alzheimer's disease. And at this point in time, this is an excellent place to be in terms of Alzheimer treatment, because we've got new medication that is available and is approved and can be utilized for the management of Alzheimer's conditions. So again, reaching out to all of you. If you know someone with Alzheimer's disease and you want to learn more, please schedule a NeuroChat, Neuro2Go.com, or just call and make an appointment and bring that loved one in. I'm happy to evaluate, and in so doing, if Aduhelm, the new medication, is appropriate, we'll prescribe it. So I thank you for your attention today. I look forward to speaking with you more about this compelling topic. But again, now is the time to act, because early intervention means effective treatment. And on that note, I'm going to wish you all a great afternoon. Thank you for logging on. feel free to contact me via nerdigo.com or make an appointment. I'm available, and I look forward to speaking with you further. Thank you. Have a great afternoon. Bye-bye, everyone.